Okay, hello everybody. Welcome to this presentation where we want to talk about assisted vaginal delivery. What are the outcomes of this presentation? So number one, we want to describe the indications and the prerequisites, those conditions that must be met. Those are what we are calling the prerequisites. And then each of us will get a chance to watch videos on the same, and then we'll outline some of the contraindications, or when do you say this procedure has failed, and then we'll look for other ways of delivering this baby. We'll also look at the appropriateness of forceps delivery. So you hear people talk about instrumental vaginal delivery, others talk of assisted vaginal delivery. Essentially these are the same, different terminologies essentially meaning the same thing. So why do we need to talk about assisted vaginal delivery? So you find that the world over, a good number of maternal deaths are caused by complications of prolonged and obstructed labor, and most of them occurring in the developing world, up to 4 to 13% of these deaths. And most of you will agree with me that if you want to do a cesarean section in second stage, it becomes a very, very tricky cesarean. In fact, there are so many complications that can arise out of such a cesarean section. Things like puerperal sepsis, injuries to the ureter, injury to the uterus, at times the bladder, or even causing iatrogenic fistulas. So, even as we talk about AVD, let's appreciate that at times it can fail, and you may need to go for other alternatives, things like cesarean section, and destructive procedures in case of non-viable fetuses. So why talk about AVD or assisted vaginal delivery with everybody? Why are we not choosing who to train or teach this and who not to? We find that if you look at the 7 basic functions at the level of a basic essential or emergency obstetric care facility, one of the bare minimums you need to be able to offer is assisted vaginal delivery. So in essence, we all need to be familiar with this. So in developing countries, we don't do so much of AVD, less than 1%. But if you look at developed countries, quite a number of deliveries, 5 to 20% of them, actually via assisted vaginal delivery. So what are the options for AVD? You have your forceps on the left, and then on the right you have your vacuum extraction, which we are going to go into details and see how it's actually done. So let's look at vacuum extraction. What do you want to see? Well, what do you want to know about vacuum extraction? We want to know the indications. We look at the conditions necessary, what we call the prerequisites. Before the procedure, how do you prepare? How is the actual procedure done? And after the procedure, what actions do you need to take? So let's look at some of the indications. So think about those conditions or those situations that might necessitate shortening of the second stage of labor, or intervening because of a reason or the other in second stage. So you can start thinking of indications like prolonged second stage, or a mother with medical conditions or conditions that will warrant you to shorten that second stage of labor. Things like cardiac disease, or conditions like anemia, or your patient is eclamptic or has severe preeclampsia and you want to hasten that delivery in second stage. So you could consider using AVD. Again, when you want to assist deliveries in the occipital posterior or occipital transverse positions, like we know, second stage can take quite some time in these positions. So AVD is a good alternative to shorten that second stage in such positions. Again, fetal distress in second stage will be another indication. Things like cord prolapse in second stage. Think of things that may want you to get that baby out very fast with that lady in second stage. So conditions necessary, what you're calling the prerequisites, those things that before you do the vacuum delivery, you must have ensured that they've all been catered for. Like, let's look at a few of them or some of them. So the pregnancy needs to be term, 36 weeks plus. But you can still do it at 34, 36 weeks. Again, if you are cautious enough and you are experienced enough, you have the expertise, it can still be done at that gestation. The baby needs to be live and in cephalic presentation. In case the baby is dead, please let it be fresh. You don't want to start pulling a macerated baby. We can all imagine what will happen if that is to be done. The cervix needs to be fully dilated. Its head at station 0, and please, descent should be nothing more than 1/5. Meaning, if you have to palpate any part of the fetal head above the pubic symphysis, please let it be 1/5 and below, nothing more than 1/5. Informed consent is very, very important, and then the equipment you are using, of course, needs to be functioning. Finally, the mother needs to be cooperative and needs to have good contractions. So, before you do the procedure, how do you need to prepare? Let's see, what are some of the things that you need to have ready with you? Make sure your equipment is functioning. Again, you'll see this in the video, how to ensure this is your equipment is working by checking for suction on a gloved hand. You'll be shown this. And then, please, gain consent. Informed consent is very, very important. This lady needs to know what you want to do, why you are going to do it, how you are going to do it, what are the anticipated complications as you do whatever you are planning to do, and what are our options. So all these aspects of consent need to have been taken into account while gaining the informed consent. Respectful care is very, very important. Make sure that lady is positioned in a comfortable way. And infection prevention, washing your hands, put on gloves, draping that lady, very, very important. That bladder needs to be empty. In case it's full, catheter in, bladder emptied, catheter out. Or in case you want to retain the catheter, please deflate the valve. Yeah? You don't necessarily need to do pudendal blocks, but if you are able to infiltrate the perineum with the local anesthetic, it gives good pain relief, and of course, your mother gets to cooperate better with you if she does not feel as much pain. Good. Now, at times you want to do your vacuum delivery and the head is in the occipital posterior or occipital transverse position. You can attempt manual rotation of that head, because if you are able to succeed in doing that, the likelihood that your vacuum delivery is going to succeed is actually very, very high if you do that. So how is this done? Hold that head cupped in your hand. That is, hold the head in a cupped hand, and then you want to disimpact it slightly in between contractions. So you disimpact it and rotate it in between contractions, because if you are able to do this, like I said earlier, apart from your AVD chances of success going higher, it avoids the need for you to do rotational AVDs, in that if you're able to rotate it manually, you may not even need to do the AVD altogether. This labor may just progress without you needing to intervene. So if you need to rotate in a manner other than the manual rotation, please do it in theater so that you are ready to jump to a cesarean section the moment you are not successful in that. Good. Assemble your equipment. Choose the appropriate apparatus. We have the kiwi and the Malmstrom. With the kiwis, you have the hard or the rigid cups. That's your Omni cup. Then you have the soft or the flexible cup, which is your Pro cup. Again, we'll get to see this in the videos that are going to follow. There's the Malmstrom, which you'll also get to see. Make sure your apparatus is functioning, and of course you cannot use something that you're not familiar with. So it has to be something that you are familiar with. Checking suction on a gloved hand, again you'll get a chance to watch this and see how it's done. So the types of equipment I was talking about. So on your left is your Malmstrom. Essentially needs 2 people to operate. Yeah? And then on the right, those are your kiwis, where you have the kiwi Omni cup. That is the rigid cup, and then you have the kiwi Pro cup, which is essentially the flexible cup. So before you start to apply that cap, you need to appreciate the position of that head. It is very, very important for you to do this. And how do you appreciate position? You need to ask yourself, how is this baby's head oriented in the maternal pelvis? So where is the fetal occiput in this pelvis? Taking into account that the maternal pelvis has a right and a left side, we have the anterior aspect and the posterior aspect. So how are you able to appreciate the head in the pelvis via vaginal exam? So you need to differentiate the anterior from the posterior fontanelle, and of course feel the sagittal suture running between the two fontanelles. Your anterior fontanelle, of course, will be a bit wider, admitting about 2 fingers. It's diamond shaped, and you're able to appreciate the 4 sutures running away from it, as opposed to the posterior fontanelle that will be a bit narrower, probably admitting tip of your finger, with the 3 suture lines running away from it. So when that head is felt in the pelvis and you are able to feel the position, in that you can tell where the fetal occiput is, where the posterior fontanelle is, and you can be able to appreciate how the sagittal suture runs, then it becomes easier for you to get the position. For example, like what you can see there. So the occiput is towards the anterior aspect and more towards the right aspect of the maternal pelvis, making that position right occipital anterior amongst the 7 other positions. Good. So let's look at application of the cap. So you need to tell the mother what you are now going to do next, which is apply the cap. Again, get the largest possible cap. Again, in the videos you'll get to appreciate how you depress the foresheet posteriorly. Apply your cap. And then what's important is that you want, as much as possible, to have the center of that cap on the flexion point. So what is the flexion point? So the flexion point, simply put, is a point that is about 2 to 3 centimeters from the posterior fontanelle, moving anteriorly along the sagittal suture. So why are we calling it the flexion point? Because if you pull the head with the cap on that position, the head assumes a posture of maximum flexion, which is what naturally or normally occurs. So you want to try and see to it that you achieve that position, because that will make your delivery much easier. So after you've applied that cap on the flexion point, check that you've not caught any maternal tissue, because you don't want to start giving this lady tears and PPH infections and the rest coming in. So that's a demonstration of how the cap is applied. You get to see this in the videos. So after you apply the cap, start creating your vacuum. So keep creating it up to the yellow mark, which is essentially 0.2 kilograms per centimeter squared of vacuum. You'll get to see these colors, the yellow, the green, and the red on the kiwi. Even in the video, do not worry about that. Good. So you apply your vacuum to the yellow mark. Check that you have not caught any maternal tissue. If there is none, keep applying your vacuum to the green mark. So all the way to the top of green, just before you get to yellow, which is at the 0.8 kilograms per centimeter squared of vacuum. Please keep checking. Even after you get to the green point, keep checking. The point of checking is that if you are able to feel that you have caught maternal tissue or the soft tissue trapped in between the cap and the scalp, it's simple. Just release vacuum, reapply your cap, and repeat the whole process. Ask the woman when the next contraction starts, because again, remember, you are assisting her, so she needs to be pushing even as you're pulling. Good. So with each contraction, ask her to push. As she's pushing, you pull. Every time you pull, ensure that the stem and the cup. Again, in the videos we'll demonstrate, or rather we show you what do I mean by stem. So the stem and the cup need to be at a perpendicular angle and pull in line with the pelvic axis. So there's a way the maternal pelvis is oriented, yeah. So you pull in line with that axis. Again, in the videos we'll get to show you this. So in between contractions, always stop and listen to the fetal heart and check that the cup is still in position. Good. So if there's no contraction, I said no contraction, no pulling. No contraction, no pulling. As the head descends, decide, do I need to give an episiotomy or not? Remember, you will not always need to give an episiotomy. Why is this so? Why is this so? Because if you compare the diameter of the cup to the diameter of the fetal head, it is much smaller. So it doesn't necessarily mean that once you've applied the cup, so you've increased the diameter of the head. Not really. So an episiotomy will not always be necessary. But if you have to give an episiotomy, please give it with lignocaine. Infiltrate your lignocaine before giving the episiotomy. So continue pulling up to a maximum of 3 contractions or 3 pulls. But these are not cast in stone. Remember, you might have pulled thrice and the head is just about to be delivered. It's not delivered yet, but you've made so much progress, you are almost there. In such scenarios, of course, you're allowed to go for a 4th pull. Good. So when the head is delivered, release the vacuum, remove the cup, and conduct that delivery like you would in a normal delivery. So after the delivery, active management of 3rd stage is still done. It's very important. Repair any perineal tears or any trauma that the lady might have suffered. Please let us document. There is one very bad habit of most of us failing to document our failures. In that someone fails to succeed in the delivery, they do not document. But if they succeed in delivering that baby, they will document in all the available registers. So let us make it a habit to document. Just document. And then observe that baby, and whenever you can get the services of a neonatologist, always call them to come review the baby. So when do you say this vacuum has failed? When do you say we are not going to deliver this baby and let's look for alternatives? Number 1, with each pull, that head is not advancing. Or you've pulled thrice, that head is not delivered, or it's not about to be delivered. Again, an indication that you are failing, or the procedure is failing. If that cup slips off the head twice, you've applied it properly, you've given it enough vacuum, you're pulling in the right direction, but that cup is slipping off, that happens twice, kindly stop. Or you've been pulling for more than 20 minutes, that baby is not delivered or is not about to be delivered, kindly stop and consider an alternative, which will be a cesarean section or symphysiotomy. Good. Complications may arise. Of course, the mother may get genital tract injuries. That's why I kept singing, please check, please check, please check. The baby may get scalp edema or a caput. Again, this will clear in a day or 2. Scalp abrasions and lacerations. Cephalohematoma can also develop. But again, this will also clear in 2 to 4 weeks. So some reassurance may be all that you need. Neonatal jaundice in the case of a resolving hematoma, and a subgaleal or intracranial bleed can also arise. So when you cannot get a neonatologist, what do you look out for? Check that baby's swelling is not increasing, the hematocrit is still okay, and that bilirubin doesn't seem to be rising. I talked about a cephalohematoma clearing spontaneously, so no need to worry as much. So when can you consider using forceps? You've conducted your breech, the head is stuck, consider using your forceps. You're doing a cesarean section, that fetal head is quite high, again, forceps can be used. Cord prolapse, you want to speed up that delivery, forceps may be used. But remember, the prerequisites for AVD must still be met in that scenario. Fetal distress in preterm labor in second stage, may use your forceps. And something funny about forceps is friendly to the baby, but not so friendly to the mother. So injuries are more to the mother with the forceps than to the baby, and of course the reverse will be true with a vacuum. So only a skilled operator should use the forceps. Okay, thank you. So what have we said? Let's remember the indications and the prerequisites, those conditions that must be met for assisted vaginal delivery. Let's always remember contraindications, which essentially will be the opposite of the indications. And let's remember what we discussed as some of the indications of forceps delivery. Thank you.